Hello, welcome to DM Neurology Made Easy. This is the 14th episode of 5 Neurophilia Quick Revision series. Let's see the demyelination part 1 video.
This is the time when we have to start learning properly, because I think within 3 months we'll be having, within maybe 2 to 3 months we'll be having our exams. So if you are right now procrastinating, try to find out where this vicious cycle, which loop we have got stuck in, and try to change it. I think these kind of videos and all classes would be more than enough to get you motivated. And once you motivated, you have to keep this habit going. So any habit, anything you keep in your daily practice, if it you keep it for just 21 days, 21 days, if you keep it regularly, if you are practicing it regularly, it becomes your habit. So till 21 days persist, have a habit of keeping it persistent, and then it will become your habit. So if you are planning to wake up at 6 a.m. Or 5 a.m. or have a specific timetable, spend a certain amount of time for your studies, try to be persistent and consistent, especially in that, for about 21 days, and definitely it will become your habit. And put effort into that and train your brain. Never think that okay, I'll get a rank 500 rank, 600 rank because I'm a fresher, and institutes are not my cup of tea, and they are actually out of my league. No, actually we have got something called neural plasticity. So if once the time you think that, okay, I want to be in AIMS, JIPMER, PGA, or Sri Chitra, and you put your effort, that neural plasticity comes in, and more synapses are formed. So if you train your brain hard, definitely you will achieve your goals. But it may take time, and it depends basically on your willpower and your efforts. So that will help you in your growth. And definitely one thing is that it's not the competition with others which matters the most. It's the competition within yourself. That is, you should be a better person than what you were yesterday. Bit of motivation. We'll start this session today. So this is regarding multiple sclerosis. So I'll tell you that multiple sclerosis is a demyelinating disease for sure, that which all of you know. But before that, you should know that it's actually just the body. If you consider this multiple sclerosis as a part of a demyelinating disorder, it's just the body. It has got a head and a tail. The head will be considered like any demyelinating disorders. Lots of demyelinating disorders are there in the human, while considering the diseases within our human system, and that will consider the head. And the tail would be the newly found out demyelinating disorders like NMO and the Moog spectrum kind of disorders. So we have to know this head first. So if you have a deja vu of what this question comes up, if you see this question, you may have a deja vu, because this same question, similar structure, was asked in the peripheral nervous system module as a first question. So try to answer this question. So I'm launching the poll, and you should understand that if you get it wrong in this question, then you should understand there is something wrong in your study technique. If you are following this Fine Neurophilia series and you are correctly studying everything, there is something wrong. You have to go back and study, especially the peripheral nerve modules or peripheral nerve system, what you had completed. Yes, it's the oligodendrocytes. So if you remember in the peripheral neuropathy series, we had discussed regarding the support system of the central nervous system. They are 5 in number, and of which the oligodendrocytes are the ones which help form the myelin within the central nervous system, and the counterparts in the peripheral nervous system are the Schwann cell. And astrocytes are the ones which give nutrition and forms the blood-brain barrier within the central nervous system. So these are just a revision of what, and these forms the basics. So as you know, oligodendrocytes are the ones in the central nervous system, and one oligodendrocyte forms covers multiple neurons within the central nervous system by forming myelin. And these are type 1 myelination occurs in the central nervous system, and type 2 within the peripheral nervous system. And what we are going to study is about demyelination. So there is this, that is destruction of myelin, or something is happening to the myelin. So first of all, we should know what this myelin is. You must have learned that it is something like a fatty substance or something, but more to it you should understand, because the pathology, understanding the myelin will help you understand the diseases which affects the myelin. So it is actually 40% of it is actually water, and 60% is dry mass. And of this dry mass, 70, 3/4 is made of lipid, and 25% is of proteins. And any pathology, even affecting the water within this myelin content, will cause demyelination. So that will be what affecting. So any acid-base imbalance or water disturbance that occurs within the within our human body, as occurs in case of what you call osmotic demyelination, that is central pontine myelinolysis, extra pontine myelinolysis, etc., will cause demyelination. So that is the crux here. And as you know, this lipids and proteins, as we said, lipids are 75%. That is why it forms the insulation with above the nerves, and proteins are 25%. And when you go through the Harrison and Bradley, and we see lots of molecules coming in, like antibodies against the myelin basic protein, and you know the separate entity of disease of MOG, that is myelin oligodendrocyte protein. So these are actually contents within the protein contents within the myelin. So these when get affected due to the various disease processes, results in demyelination. So galactocerebrocyte, if get affected, it results in there's dysmyelination syndromes, as in pediatric demyelination syndromes. Sphingomyelin getting affected, cholesterol getting affected are causes of pediatric dysmyelination syndromes. So if you consider the disease of myelin, it could be divided basically into dysmyelinating and demyelinating disorders. Dysmyelinating ones are the primary disorders of the myelin. So the primary metabolic disorders of the myelin. And demyelinating ones are the destruction of myelin. And some diseases are hypomyelinating, that is reduction of myelin synthesis, which could be due to congenital problems, or delayed myelination. So we'll be concentrating mainly about demyelinating, but we'll have a quick brush through the dysmyelinating ones. So the dysmyelinating ones are basically, as I told you, are primarily metabolic problems, that is metabolic problems affecting the myelin. So they include basically the pediatric dysmyelinating disorders, as we have studied: adrenoleukodystrophy, ALD, that is ALD, metachromatic leukodystrophy, Krabbe's, Alexander's disease, Canavan's, PMD, phenylketonuria, etc. And the demyelinating ones is not just multiple sclerosis alone. It contains a whole array of diseases. As I told you, if water is, even if water forms a component of myelin, so if water is getting affected, as we can see here, central pontine myelinolysis is actually a central pontine myelinolysis is actually occurring due to, I'll just take the pen. I was trying to take the pen. Marker. Okay, fine. So central pontine myelinolysis you see here, right? So that is a problem within the water content. So all this autoimmune, infectious, toxic metabolic, vascular, due to the decreased blood supply to that region, as in case of Binswanger's disease, etc., causes demyelination. And multiple sclerosis is just one cause of demyelinating disorder. So this table is from Bradley. And if you see, I had you know about reading the MRI. So if you know what is this MRI, if you see this MRI, you know that the gray matter is whiter in color and the white matter is darker here. This is due to a tissue destruction process that this dark matter is getting whiter, or that is T2 hyperintensity, because CSF is white here and gray matter is whiter and white matter is darker. So in this T2 weighted image, you can see that there is actually symmetrical white matter hyperintensities, and there is symmetrical white matter hyperintensities with stripe-like appearance here. So if this symmetrical appearance helps us, appearance helps us differentiate the dysmyelinating disorders from a demyelinating disorder. So this symmetrical, this stripe-like appearance is called a tigride appearance, which is seen in metachromatic leukodystrophy, also could be seen in Pelizaeus-Merzbach's disease. So if you see here, this is also a T2 weighted image because water is white here, gray matter is white, and white matter is darker. So T2 weighted image. If you see here, there is bilateral white matter hyperintensities, and I would suggest, I would like to say that it is asymmetrical. But if you argue with me, I would have to give in and try to say that it is symmetrical. So one more adjective to add in case of how to differentiate between a dysmyelinating and demyelinating disease would be that more than symmetricity, we have to add that whether it is a confluent white matter hyperintensity or a patchy white matter hyperintensity. So a confluent symmetrical white matter hyperintensity will point towards a dysmyelinating disease, and a asymmetrical patchy hyperintensity would point towards a demyelinating disease. This is a typical MRI of a multiple sclerosis patient, and this, as you see, is a periventricular white matter hyperintensities radiating from the periventricular region. These are actually the Dawson's fingers, very well seen if you see the sagittal section of the MRI. So with that, we'll go to the next question. So these modules are to help you read and read the text and emphasize on the portions where you must have missed out while reading the text. Okay, most of you have answered it as may occur with physical exercise. Yes, right. So they are actually bilateral visual blurring which occur due to heat sensitivity and not due to cold or other symptoms. And it is not due to decrease in body temperature, but due to increase in body temperature. So what is this heat sensitivity in multiple sclerosis producing these transient symptoms called Uhthoff's phenomenon or Uhthoff symptoms? So this occurs due to transient conduction block. So as you know, the patient with multiple sclerosis are perfectly healthy except for these kind of transient, focal symptoms. And these patients, when they try to walk or do exercise or get a fever, then they develop these kind of transient symptoms, and so also gets exaggeration of their symptoms which they were having. So if you want to give an advice to them to go for a perfect exercise for them, the ideal exercise for them would be to go for swimming in cold water rather than a heated exercise. These are the oligodendrocytes, which gives multiple myelin sheets around the axons in the central nervous system, and they are perfectly working in sync so that there is message transmission within the brain. Due to some disease process, there is destruction of both the oligodendrocytes as well as the myelin. You can see what are these cells. These T-shaped cells, these are actually the T cells. So these T cells are the main culprits regarding which causes the multiple sclerosis. And further, there is addition of B lymphocytes. So both T cell mediated as well as the humoral immunity both acts in causing multiple sclerosis. If you read further in the textbook, then now you will get to know. And that is why all the disease targets are acting on both T cells as well as the B cells. So in a normal conduction, as we have discussed in peripheral neuropathy chapter, it would have been a saltatory conduction. It would have gone at a speed of 70 meters per second. But when when a nerve is stripped of the myelin, the speed is reduced. And why it occurs, we will see. So when the myelin is when there is saltatory conduction occurs due to conduction along the nodes of Ranvier, and in the nodes of Ranvier we have the concentration of sodium channels, and there is jumping of these conduction across these nodes of Ranvier because there is insulation with this lipid-rich myelin across these internodal area. And if you see, there is sodium across. So you may think that this is the sole reason why we have this saltatory conduction. And when there is this, there is a stripping of this myelin, there is exposure of sodium channels. So there is multiple sodium channels which open up here. So that causes the time consumption of the sodium channel opening and thus slowing of conduction. Yes, that is one of the reason why, because of the multiple exposure of this sodium channel in the naked axons, that causes the slowing of the conduction across the this naked axons, that is the demyelinated axons in case of multiple sclerosis. But there is one more cause for this, that is in between this myelin, that is in the nodes of Ranvier, there is potassium channels also. We know there are sodium channels, potassium channels, also there is sodium potassium ATPase. There are also potassium channels in between also, that is in between the internodal area. The specificity of the peculiarity of this potassium channel in the nodes of Ranvier is they are slow channel, and the specialty of the potassium channel in the internodal area is they are the fast channel. But contrary to what we think, the fast channel ones causes repolarization. So you know, if you remember your first year physiology regarding action potential and all, the repolarization this slow potassium channel actually causes repetitive firing of the action potential. So if this fast potassium channel causes repolarization, and if it is exposed, it causes dampening of the already slowed action potential in case of demyelination. So if this is stripped off, this layer is stripped off, along with the sodium sodium channel getting exposed, potassium also get exposed, that to the fast ones. And also you have potassium here also. So of this one will be more exposed and there will be further dampening. So just to add the point that in Harrison, they have point out the fact that the sodium getting exposed in case of a naked axon will result in slowing. But in Bradley, one more point has been added, that is regarding the potassium channels. So with that introduction, I'll just, since I have already given you the answer for this question, I'll just want you to process that knowledge. So that is why I have put this question to you. And I have already told you that fast potassium channels are present in the internodal area and the slow potassium channels are present in the nodes of Ranvier. But contrary to what we see, that fast ones, we think that they fasten the action potential, but contrary to what we believe, the fast ones causes repolarization and actually dampens the potential, and slow ones causes repetitive firing and actually fastens the potential. And in all these repolarization and depolarization are balanced with the help of sodium potassium ATPase. So a step ahead from what we learned from Harrison, Bradley has given these facts. And I am just asking you a basic question which we learned in physiology. That is the wrong statement here. Actually, opening of sodium channel causes sodium influx rather than a sodium efflux. So read the question properly every time you answer. So this is the explanation for that. Action potential propagation causes sodium influx rather than efflux. So that clears the point in Bradley. And with experience only, we will be able to diagnose MS very easily. And after having this clinical suspicion, we have to go through a clinical diagnostic criteria before starting these specific drugs for MS. So MS, as you know, it is actually demyelination, and demyelination occurs in the white matter tract and not in the gray matter. Mostly it's in the white matter tract. And white matter tract could be in the optic nerve tract, it could be in the motor tract, sensory tract, cerebellar pathway, etc., etc. And based on this, we have multiple problems. And you should know the fact that pain is one of the most common symptom experienced by MS patients, and it is present in more than 50% of the patients. And there is one popular adage, that is, if a patient comes with symptom in one leg, so if a patient comes with a paresthesia in one leg, usually we think of IVDP or any symptom like the peroneal neuropathy, IVDP, etc. And while examining, you find that the patient has signs in both legs, that is either reflex loss or paresthesias in both legs, or some other symptoms in both legs, then definitely have MS in your back of your mind. So that popular adage is a patient presenting with symptoms in one leg and signs in both, think of MS. So that could be. And optic neuritis in MS is usually unilateral. And if it is bilateral, you have to think of other causes. It is not that MS cannot be bilateral, but it is mostly unilateral. And if it's bilateral, we have to think of other diseases. And MS presents with other diseases also. So it can present as even Bell's palsy, that is also present as tic douloureux, that is trigeminal neuralgia, facial myokymia. It can present as constipation, urinary bladder symptoms. It does not necessarily mean that you may think that it is always UMN bladder the patient would be having. If the patient has MS lesion, that is MS kind of lesion over the sacral region, then the patient may have urinary retention also. It is based on where the lesion, white matter tract, where the lesion occurs, the findings differ. So the answer for that one, I forgot the question. Optic neuritis in MS is actually unilateral rather than bilateral. So this picture summarizes what you need to know regarding these diseases. MS occurs almost in the middle middle two-third of the optic tract, and it is mostly unilateral. And NMOSD, as the term itself says, neuromyelitis optica, that is aquaporin 4 related. So it is found in the lining the ependymal cells or the ventricular area. So chiasma is somewhat related to ventricular area. So it will be more near to the chiasmal region, and it will be more posterior, and MOG will be more anterior. So keep this picture in mind every time if some MRI is shown to you and it has a lesion like this. If unilateral, there is no doubt you should first think of MS. If bilateral and chiasmal region is affected, think of NMOSD, that is aquaporin 4 related, and the other one was the MOG, and it will be more anterior. If anterior, then papilla, that is the optic disc and all, will be more affected. For example, if this MRI is seen, so again I am asking you, what is this MRI? This is gray matter is white, so and white matter is dark. So this is a T2 weighted image, and this is water within the eye. So this is water is white. So World War II. So this is T2 weighted image. In this T2 weighted image, you can see that this area is T2 hyperintense, and this is almost the middle two-third of the one side. So unilateral optic neuritis. I am not saying this is necessarily MS, because one lesion, this is actually gray matter. So no other lesions, but this could be MS rather than NMO or MOG. And this one is more likely to be NMOSD because we have the chiasmal and the bilateral involvement of the optic tract. So more likely NMOSD. And this one is more anterior and bilateral. This one could most likely be a MOG disease. And as I already told you, simultaneous optic neuritis is rare. But if it occurs, we have to think of other causes like MOG, NMO, toxic neuropathy, or Leber's hereditary optic neuropathy. And if in MS bilateral optic neuropathy occurs, it will most likely be asymmetric and will be severe in one of the eyes. And I'm talking more about visual problems because that will be the most presenting symptom in your MS patient. So that sensory and the visual symptoms are most common presenting symptoms. So if more than MCQ in your clinical practice also, we have to have to know this fact. Which of the following is unlikely in optic neuritis associated with multiple sclerosis? Straight direct question from Harrison. Desaturation, dyschromatopsia, diminished visual acuity are all usual findings, but there won't be any complete loss of light perception in case of multiple sclerosis. Most of them have answered it correctly. Some additional points is that optic nerve in the visual pathway anywhere could be affected because they are all tracks, of which optic nerve is the most commonly affected site. And the most common finding would be a central or the centrocecal scotoma. So the picture in the this HFA Humphreys field analysis would be a centrocecal scotoma. And you get a relative afferent pupillary defect because the optic nerve tract is affected. But as I told you, if you see that it doesn't reach, it is in the middle 2/3 of the optic nerve. So most likely it won't reach the fundus part. So usually the fundus will be normal, especially in the early part. So there will be no papillitis. It is actually retrobulbar neuritis. The patient will be having these kind of findings of all this optic neuritis as explained before. And patient will be having also pain while moving the eyes. And the fundus will be normal. So this is, the patient sees nothing. It's not nothing because there is no complete loss of vision. And examiner or the doctor doesn't see anything because there is no papilledema or fundus abnormality. And this is the usual finding in retrobulbar neuritis. And you should know that 90% of the patient regain the normal vision by about 6 months. And pallor of optic disc, optic atrophy commonly follows optic neuritis by about 1 month to 2 months after a optic neuritis. So you must have heard of Charcot's triad. That is during the MBBS period, you must have heard of Charcot's triad. It is associated with which disease? You can put in the chat box. Charcot's triad is associated with, cholangitis, right? So what is Charcot's triad to do with MS? As I told you, Charcot's this MS affects all these tracks. So we divide this. If it will be easier for you if you divide this affliction of MS into visual pathway disorders, cerebellar, sensory, motor, etc., etc. So now it's easy for you. That is, it is the cerebellar pathway. So it is nothing connected with visual or sensory. Most of answered that like that, but it's associated with cerebellar. So this could be one of the presenting symptoms. You may think that this multiple sclerosis always presents with Lermit symptom, Uhthoff phenomenon, presents with spasticity, hyperreflexia, visual optic neuritis, etc. But it could present as a pure cerebellar symptom with nystagmus, intention, tremor, and cerebellar findings like Charcot's triad. So that also you should keep in mind. So which one of the following is not a feature of multiple sclerosis? So if you can see, this is facial myokymia, and in the option I had put it's facial myorrhythmia. That is not a feature of multiple sclerosis. Facial myokymia usually is seen below the orbicularis oculi, and I have shown this video that is below the orbicularis oris. That is also a facial muscle, but usually is most commonly could be seen that is a small undulating wave-like twitching below here. That is in the facial orbicularis oculi below the eyes. So facial myokymia is a clinical finding in MS. So don't think that is always if you see a facial myokymia, it is always MS. No. It could be also a finding along with other findings of MS. If you find a facial myokymia, then it's MS. Otherwise, you also have to think of other lesions like a brainstem glioma near the pons or pontine glioma, etc. You have to think. And regarding Pulfrich effect, that is the reason why this question was put. This is actually a problem with the delayed optic nerve conduction. So as discussed above in the previous questions, you know that optic nerve gets affected. There is definite affection of one-sided optic nerve. That is unilateral optic neuritis occurs in MS. So optic nerve conduction is delayed. So in such a patient, what happens is that when a light from one object comes to the eyes, one side of the one eye perceives it normally, but the other eye doesn't do that normally. It takes time. So there is delay in this process, and that apparent delay causes the patient to believe that something is wrong in the uh, perception. So I'll explain. So you should know one thing, that in such a patient, the Pulfrich effect, what it causes is that uh, the patient feels that everything is coming in a wrong direction. A two-dimensional movement is perceived as a three-dimensional movement, and the patient may feel as if something is going to come and smash onto him, because I'll tell you, this patient was sitting on a bus and it was moving straight, and another bus was trying to overtake this bus, but to him that bus was not going as a straight line in 2D, but it was trying to curve in because of the perceived perceived apparent deviation because of this Pulfrich effect. So if you put a pendulum in a case of a pendulum in swing a pendulum in front of a Pulfrich effect, that is in a multiple sclerosis patient, this patient will have the feel that the pendulum is going in a anti-clockwise or a clockwise direction rather than swinging forward and backward. So what is it in the clinical relevance? What is this in clinical relevance is that if you see this picture, a patient sitting in the car, and as I told earlier in that bus scenario, the patient driving a car will have difficulty in driving because the patient feels that every time a car overtakes him, it is trying to bump onto him or hit him, either ways, if it is in the right side or the left side. So the such patients, a multiple sclerosis patient will have difficulty in driving. So a driver getting a multiple sclerosis having optic neuritis or any optic neuritis will have to will have difficulty in continuing his profession as a driver. So that is the importance. What I wanted to, you can see that even the eye as well as the face are actually having this rhythmic movements. This is actually oculomasticatory myarrhythmia that is seen in Whipple's disease. Just for your knowledge, I had put that option.